Hi, my name is Samantha, and I'm going to be demonstrating a barium study on our patient here for my capstone project on Diagnostic Imaging 3. So for barium studies, typically the indication for barium studies would be vomiting, diarrhea, foreign bodies, abdominal masses. You want them fasted for about 12 hours, which is ideal, or 24 if you're looking at the mucosa or the lining of the stomach or intestines. Contraindictions, or where you wouldn't do a barium study, would be fluid-filled or distended esophagus or stomach, ileus due to torsion, if the bowel is atonic or lacks muscular tone, or all be reasons not to do a barium study. For our patient today, we're going to be using the barium sulfate suspension 60%. So for our dog here, we're estimating we're about 15 pounds. So I went ahead and did my calculations. You want to do about 8 to 10 mils per kilogram. So he is 6.8 kilograms, so I calculated out at 54.5 mils today. So we'll go ahead and do our first scalp film on the right lateral side, and then we will administer the barium and then follow up with an x-ray right lateral VD. If this was a real barium study, what you would be doing is you would be doing 4 scalp films. So that would be a VD, a DV, a right and left lateral film. Then you would take a VD and a lateral at 15 minutes, 30 minutes, 60 minutes, and then every hour until it reaches the colon. Typically at 15 minutes it will be, the barium will be in the stomach and the duodenum. At the 30 minutes it'll be in the stomach and some of the small and large intestines, and then and so forth. It would keep traveling until it hit the colon. If it is, if there's not gastric emptying in 30 to 60 minutes, it's considered slowed. So we'll go ahead and I'll demonstrate positioning the patient today and collimating. I will also demonstrate all the proper protective equipment you're supposed to wear. Since I am pregnant, I'm still going to leave the room and hit the button from outside the room because I don't want to be in the room when I'm taking my x-ray, but I'm going to go ahead and position it all and describe what I'm doing. So for this patient in a barium study, if he is sedated, a lot of times you're not going to sedate because you don't want to slow down the GI tract, so they would be restraining with their hands on his side. You want to make sure that you have the front limbs pulled forward and the hind limbs pulled back. Demonstrating, while I won't have anyone demonstrating, I went ahead and taped the limbs that way, and you can put a sandbag on the neck if this patient in theory was sedated. We would go ahead and, since he's on his right side, make sure we have a right marker, and we're going to collimate. You want to make sure for a right lateral view, you're going to have the upper part of your view box around the diaphragm. You want the apex of the heart in there, and then the caudal part at the coxofemoral joint. You want to make sure you're collimated properly to avoid any scatter radiation. And we want to have your marker so you know that you're on your right side. Up here, it's hard to see, I have entered in that we are a dog, that we're doing the abdomen and lateral. So now that I'm in the position that I'm going to be in for the x-ray, you want to go ahead and use your caliper and measure. And you're going to measure about the 13th rib, or the thickest part of the x-ray. So obviously we're very flat being a stuffed animal. I'm just going to put it at 5.
Is that a concern? That's a concern. He's like a midget too, so like a little guy.
So since it is kind of hard to see. My KVP is at 70. My MA is at 400, which makes my MAS at 4. I'm in my lateral dog abdomen, and I have set it to 5 centimeters. I am putting on my glasses, glasses and my gloves. If I was in the room and restraining, you would want to make sure you have your thyroid shield on, your lead gown, your gloves, and your glasses. So I'm going to go ahead, and now that I'm sure I've collimated appropriately, I have my gadameters, I'm going to take the x-ray from outside of the room. All right. And on my x-ray, you can see this little fuzz from the fake stomach that we have and the marker. So we got, it looks like we have good collimation. And again, you would be looking for the diaphragm and the apex of the heart. You want to make sure you have the whole abdomen in there. You want to sure you go to the coxillofemoral joint. And you want to make sure you have good contrast so you can see the grays and the different parts of the abdomen, and then the black is black and so forth around the x-ray. So now that we got our primary x-ray here, we're going to go ahead and demonstrate how to give barium to our patient. And you see our patient is 18 inches here, a dog today. So we're pretty busy right now. Typically, if this was a real case, we have someone restraining in sternal recumbency, their left hand over the right hand controlling the head. And we typically do it on another table, not the x-ray table. In this case, I'm going to go ahead and put a protective drape down. You just want to make sure you're not getting any of the barium on the x-ray table to show up on the x-ray and cause artifact. So I'm going to take this off for a second because it's heavy and go through all my process of demonstrating the barium. So we have our mouth gag. I have my loop here. I have my stomach tube. I have my 54 mils of barium that I calculated. I have a couple of mils of water because I'm going to test to make sure that the tube is in the right place before I enter the barium. And then I have 10 mils to follow up the barium with, which should get it all out of the tube and make sure it's into the patient. So before you ever do a stomach tube, you want to make sure that you have the right positioning. So we're going to go ahead and have our patient restrained in a lateral recumbency. And we're going to measure from the tip of his nose to the last rib, or the 13th rib. So the end of the rib cage. And what I'm going to go ahead and do is I'm going to tape on my stomach tube to ensure we'll have the right length to make sure that it's in the right placement in the abdomen. I'm going to restrain our patient in sternal recumbency. And I'm going to go ahead and place his mouth gag in. You can use a roll of tape, or you can go ahead and use a mouth gag that you buy. If they're being difficult, sometimes we'll tape around the muzzle to make sure they're in, or you can restrain them, keeping them in. And then we'll go ahead and place our stomach tube. Again, you want to go ahead and once the gag is in, you want to lube up the end of the tube. Make sure you're slowly inserting it, and then we'll go ahead and test that it's in place. When you're administering the couple mils of water, if they cough, you know it's in the lungs. There's also sometimes you can test with negative pressure and so forth to see if you're in the stomach. So we're going to go ahead and thread our stomach tube into our patient. And real patient, you shouldn't get much resistance. And we're going to go down to where we taped. So now we have it taped off here. Depending on the syringe you're using, sometimes you can cut it off at that point. Ours have the big tips that will actually work better in the end. So now that our stomach tube is placed, what we're going to do is we're going to make sure that it's in the right place by injecting a couple of mils of water. And we didn't hear a cough. Sometimes you can also again check with negative pressure and so forth, but typically if you add in a few mils of water, they'll cough if it's in the lungs. So now what we're going to do is we're going to enter our barium, and again we had calculated for our size patient, which is about 15 pounds, we're going to do 8 to 10 mils barium per kilogram. So we're going to go ahead and inject this slowly into our patient. And you want to go slowly. It kind of gives them the feel of them swallowing when you're injecting. We're going to follow up with a few mils of water. Now that our barium is in the patient, we're going to go ahead and gently hold the end and gently pull out the tube. We're going to take out our mouth gag. So now that we got the barium in our patient here, we would move him to our x-ray table. And again, since it's a busy hospital and I'm trying not to take up much room, we're already at the x-ray table. So I'll move our drape. And again, we're going to go ahead and repeat the lateral x-ray that we just did in the same technique. You're going to do the lateral x-ray and you're going to do the repeat x-rays in theory at 15 minutes, 30 minutes, 60 minutes, and then every hour until it reaches the colon. So we'll go ahead and reposition our patient. And again, you want to make sure you measure at the 13th rib. You want your collimation to be about the diaphragm. You want the apex of the heart and the diaphragm to the coxofemoral joint. You want to make sure you have minimal dead space above and below. You want to make sure you have the right marker. Our patient has the same settings as before on the KVB and the MA, and the same measurement size because we're doing the same lateral repeat position. I'm going to go ahead and gown up in my personal protective equipment.
If he wasn't feeling crappy, I'm sure he probably would. I'll grab you a new bottle.
And again, since I'm pregnant, I'm still leaving the room even though I'm wearing all the proper equipment. to take the x-ray. I'm double checking that all my settings are correct. And then I will take this right lateral x-ray. All right, as you can tell, you can see the stomach of our patient. Since this is a stuffed animal make-believe patient, you can't actually see that we got the good margins in the x-ray. But we will go ahead and demonstrate our VD or ventral dorsal view. For the VD, here we typically will use a trough if we're not restraining, or sometimes when we even are restraining, because it helps get them in the best position.
She waited 40 minutes. No, she's not charging. Yeah, I'm not charging me after hours because she actually made an appointment.
So you want to make sure that you're holding the, if you're restraining by hand or taping, you want to make sure that we are taping the patient's torso down.
So we just have the entire.
Or holding the